Hello, everyone. Greetings to all of you attending this session on testicular germ cell tumors today. I'm Rohit Mehra. I'm a GU pathologist at University of Michigan. I'm excited to be here with you to co-moderate today's session with Dr. Sona Gupta from the Mayo Clinic and Dr. Samson Fine from the Memorial Sloan Kettering Cancer Center. I would like to take this opportunity to thank the Genitourinary Pathology Society and esteemed members of the Education Committee for coordinating this outstanding series of lectures. I would also like to extend our gratitude for the speakers who have taken time preparing talks and sharing their expertise with us. Today, we'll be listening to 4 talks from our experts on testicular germ cell tumors, and we'll be taking questions at the end of these lectures. So please feel free to place your questions in the Q&A box, and we'll be attending to these questions after the talks. Without further ado, I'm pleased to introduce our first speaker, Dr. Leonard Loenka, who will be presenting his talk entitled Molecular Biology of Testicular Germ Cell Tumors with Clinical Correlates. Dr. Loenka is affiliated to Princess Maxima Center for Pediatric Oncology and Department of Pathology, University Medical Center at Utrecht, which is a beautiful city in the Netherlands. He's a medical cell biologist by training and professor of translational patho-oncology. Since 1990, Dr. Loenka has been leading a research group studying the translational aspects of germ cell tumors, focusing on understanding the pathogenesis and clinical behavior with the aim to developing informative diagnostic, prognostic, and predictive biomarkers. His major contributions include identification of diagnostic markers like OCT4. Like you know, we have been utilizing these daily in our surgical pathology practice. So thanks to Dr. Loenka for that. He has also helped establish in vivo models for germ cell tumors and has helped discover mechanisms of chemotherapy resistance in germ cell tumors of the testes. He has given more than 200 keynote lectures and has more than 200 publications. I would love to share with the audience that all of our speakers today have contributed to the WHO classification of genitourinary tumors in different sections or different chapters. So thanks for their expertise. With this, we look forward to your presentation, Dr. Loenka.
Thank you for this nice and extensive introduction. Indeed, I will highlight a number of activities we are doing within my group currently at the Princess Maxima Center in Utrecht, and it's related to the molecular biology and clinical correlates. And I just want to indicate one potential conflict of interest. I'm a consultant of SANA biotechnology related to the field of regenerative medicine. I decided I only have 15 minutes to briefly go through the activities we've done on classification of germ cell tumors, then a little bit about biomarkers, and then finally related to our more recent activities and also the more prominent activities related to treatment resistance. And this is, of course, known for everyone. Previously, the histology of the germ cell tumors were classified based on pure how they look like through the microscope. From our perspective, this was underrepresenting the heterogeneity, in fact, of the germ cell tumors, and therefore we started, and that was published originally in the 2016 manuscript, identifying 5 and including the other one, 6 types of germ cell tumors. The prominent reason for classification is based on the origin. Where do these tumors originate from, and what is their so-called developmental potential? So what kind of histological elements could they form? Currently, and this is reported in the most recent Nature Reviews Cancer manuscript, we extended this now to 7 classifications of germ cell tumors. For today, only the 3 types are relevant and focusing on the malignant testicular germ cell tumors, the type 2. If there are specific questions, I can go through the different variants later during the general discussion. If we focus on the testicular germ cell tumors, this is nicely illustrated by this manuscript. We have, in fact, the 3 types of germ cell tumors, and those are indicated over here. We have the type 1 or the pediatric germ cell tumors. They can be both teratoma and or yolk sac tumor. We have the spermatocytic tumor, previously called spermatocytic seminomas. And we have, of course, the GCNAS related germ cell tumors, the seminomas, and the different types of non-seminomas. Here briefly indicated the history of the terminology GCNAS that was during the WHO classification meeting, and this nicely illustrates how we came from cis, IGCNU to the GCNIS. Very important is to know that the pediatric versus the adult, so the spermatocytic tumors, as well as the type 2 germ cell tumors, are also characterized by chromosomal composition. Indicated over here, we have the teratomas, hardly any chromosomal abnormality. The yolk sac, so the pediatric type 1, have various chromosomal abnormalities, but no 12p. We have the spermatocytic tumor with gain of chromosome 9 as most prominent. And we have the type 2, where all the invasive have gain of the short arm of chromosome 12. Mostly as isochromosome 12p. And I will refer to that during the presentation in more detail. It's relevant to identify that the pediatric germ cell tumors, so the type 1, are different from the malignant. These are just a number of publications where we also were partly involved, related to the epidemiological characteristics, related to signaling pathways and possible ways for alternative treatment, especially in the yolk sac related to the Wnt characterization. And we have analyzed within the Netherlands and our institute the pediatric germ cell tumors of the testes, and that's very important because for quite a number of patients those can be considered as rather benign, where also testis sparing surgery could be used. In addition, we are now analyzing the whole cohort within the Netherlands, as well as after our centralization of pediatric oncology, to see whether the care of these patients are improving. This is a very recent paper, just came out today, that in the collaboration with the MACAI, so the German registry, we analyzed the non-syndromic and syndromic defects in children with the germ cell tumors. And again, some interesting data are there to be investigated, but also used in clinical care. So already mentioned, we have different histological elements. For the type 2, all the different elements can be found. For the type 1, it can only be yolk sac or teratoma. And here are the different already mentioned biomarkers indicated. OX34, SOX17, SOX2, besides AFP and HCG. Relevant is, of course, that these markers we identified based on the comparison between germ cell tumors and early embryonic development. Indeed, these markers and targets are also used to generate regenerative medicine products from IPS as well as ES. So it's of course indeed a pleasure to notice that this classification is appreciated and the biomarkers are indeed also appreciated as being very informative, and that's simply because they are related to the biology. When there is no OX34, the cell cannot be a seminoma or an embryocarcinoma cell, etc., etc. So they are absolutely informative in the context of germ cell tumors at adult age. We tried many times to see whether these can also be used as liquid biopsy biomarkers. That would of course be wonderful because they are absolutely informative on the tissue. That is not successful. They are not secreted, and these cells are simply having these proteins within the nucleus or within the cell, but cannot be detected. In that context, there was a very interesting collaboration with the Netherlands Cancer Institute, where we identified, based on a question related whether there were specific microRNAs that could mimic the inactivation of p53. And the bottom line is that there is indeed a group a family of microRNAs, 37123, that mimic inactivation of p53. So if you have overexpression of these microRNAs, you don't need inactivation of p53 by either mutation or MDM2 or MDM4 for those cells to behave as malignant cells. And that resulted in a lot of different studies, and I just indicated some of those over here, that indeed these microRNAs RNAs are detectable in serum, plasma, as well as also cerebrospinal fluid. So they are amazingly informative for embryocarcinoma compared to the other biomarkers, York-Stack tumor, choriocarcinoma, but not teratoma. Teratoma lost all the embryonic characteristics and cannot be detected using the microRNAs. In addition, of course, there are specific requirements to have those biomarkers used for clinical implementation. Those are ongoing. There are several prospective trials ongoing, but we have now the wonderful system that we have models available also together with Robert Weiss from the US, that we have mouse microRNA tumor detection in a mouse background. We have human microdetection in mouse background using xenografting, and we have, of course, the human situation with the human microRNAs in the human background. And we can wonderfully analyze now the impact of these microRNAs, in this case xenograph models, compared to the growth of the tumor. And here you see that by surgical removal it's dropping, and regrowth the microRNAs are popping up again. So those are really stepping forward related to the use of classification as well as biomarkers on tissue and in serum. One of the still open ends, in my view, where I really am active in at the moment, is related to treatment resistance. And this is indicating from the review, we have, of course, from the 70s, cisplatin used as very effective drug for testicular germ cell tumors. And we had an overview made by one of the PhD students related to the role of p53 in embryonic cells as well as somatic cells related to germ cell tumors. And the bottom line is that we followed that up related to the CRISPR-Cas approach, where we knocked out microRNAs in germ cell tumor cell lines. And those were from different origin. They were from the mediastinal, that's a representative cell line, NCCIT, and the gonad, 2102EP. And here you see that from a classification system, you see that you can have mutations in p53 in the tumors, but you can also have MDM2 amplification. We successfully knocked out the p53 in these cell lines, and we analyzed the cisplatin resistance. And we see that there is indeed induced resistance within this cell line. So possibly that's relevant for the clinic as well. And we know that mediastinal germ cell tumors are less sensitive for cisplatin, and they have a higher chance to have mutations in p53. Again, it links also to IPS, induced pluripotent stem cells, where it can also be immutated, again showing the similarities between these types of cells. So this is the start of a study that was done together with Michael Mago in Bratislava and Friedemann Honecker and co-workers in Hamburg. We analyzed a number of resistant sublines of the NCCAT, 2102EP, and TERA2 and TERA1. We analyzed it using all different analysis, methylation, whole genome sequencing, exome sequencing, RNA sequencing, copy number changes, and microRNA profiling. The bottom line is that we could not distinguish a specific difference between the parental and the resistant cell lines till we looked at copy number changes. And here it's indicated. Here you see an amplification on the short arm of chromosome 3 in all the resistant cell lines. Also in the TERA1, that's a cell line obtained from a lung metastasis of a patient after chemotherapy. And this indeed correlated with cisplatin resistance. Then it turned out that we saw this already before. This was a case report in British Journal of Cancer, where we analyzed copy number changes in the primary tumor. Here you see the gain of 12p, and in the residual mature teratoma, here again the 12p and a 12q amplification that was found to be MDM2. And in later chemotherapy-resistant York sac tumors, almost 200 months after the primary treatment. And there again, the 3P was found. And we went through quite a number of studies publicly available from the Memorial Sloan Kettering, the TCGA, and our own data set. And the bottom line conclusions are indicated over here. The 3P amplification is more frequent in cisplatin-resistant non-seminomas. It is associated with poor PFS and overall in non-seminomas. The 3P gain is associated with overall survival in non-seminomas, excluding teratoma. So we don't see it in teratoma. That's another mechanism. Mainly, but not only York sac tumors. And this is confirmed in other studies. We show that it's an independent parameter in the context of the IgCCCG classification. Here you see it. The wild types are no gain and gain. And it adds it's independent of the MDM2 p53 pathway. We identified in type 1 germ cell tumors of the mediastinum, in the brain, and also of the ovary, also found in cell lines made resistant. And it's recently also reported to be a phenomenon in intracranial germ cell tumors. So it seems to be quite a general phenomenon. So the last two slides is that we analyzed quite a number of chromosomal abnormalities in pluripotent stem cells, and this is just a book chapter related to that. And we analyzed which chromosomal abnormalities are also found in germ cell tumors, with the idea to have additional targets for treatment resistance in the context of embryonic stem cells. And the bottom line is we analyze now a large series of proven refractory germ cell tumors compared to matched control sensitive as an identification cohort, then did the confirmation in the publicly available data sets from Bacrodia, Giganti, Memorial Sloan Kettering. And the bottom line is that we interestingly see again abnormalities that could be interesting, indicating over here with the long arm of chromosome 1. Here you see that in those particular data set, it is informative to distinguish sensitive versus resistant cell line or tumors from patients. We analyzed expression profiling, and the bottom line is, again, it's fitting within the p53 pathway. So we have the MDM2 as amplification, but now also the MDM4, confirmed also by expression profiling in the primary tumor sets. And interestingly is that also, again, in the induced pluripotent stem cells, it's recently published in collaboration with the group of Ivana Barbaric from the UK, that these cells can also develop gain of 1q, where also the MDM4 is the driving gene. So in conclusion, the bottom line is the germ cell tumors can be classified in a clinically relevant way based on their origin and their developmental potential. There are unique and highly informative biomarkers on tissue as well as liquid biopsies, OX34, SOX2, SOX17, the microRNAs. The RAS1A we are still validating as a potential biomarker for teratomas, but I still think that will be questionable. P53 seems to be very informative related to clinical sensitivity and resistance, as well as the 3P amplification, MDM2, MDM4, coming back again to the P53. And we have now various in vivo and in vitro models that can really be used to be further characterizing the underlying mechanism and going for better treatment for these patients in case of refractory disease. So we are collaborating, my group, with quite a number of people throughout the world, but based on the data we have, we are still looking for collaborations based on the proven refractory germ cell tumors, where we have now all the methods available to characterize and checking whether indeed the targets of the 3P, 12q and 1q can be validated and can be used upfront for patient stratification for optimal treatment. And I thank you for your attention.
Thank you, Dr. Luenga, for a wonderful talk. And just as a reminder to all participants, if you have any questions, please put them in the Q&A box, and At the end of all 4 talks, we'll direct them to our speakers today. Our next speaker is Dr. Muhammad Idris. Dr. Idris completed his anatomic and clinical pathology residency at Mount Sinai School of Medicine in New York, and he did multiple fellowships in gynecologic pathology, cytopathology, surgical and genitourinary pathology. He's well known in the GU pathology community, and he's currently the Louis Y. Mazzini Professor of Pathology and the director of the very highly regarded GU Pathology Fellowship Program at Indiana University. He's published more than 150 peer-reviewed articles, and as Dr. Mehra mentioned, he's been an expert contributor on the WHO panels for some time now, and he's contributed several chapters to the WHO classification as well as to many influential textbooks. Today, he's going to talk to us about trophoblastic morphology in germ cell tumors. Dr. Idris, thank you very much for joining us today.
All right, thank you very much, Dr. Rohit Mehra and Gupta. So thank you for the opportunity. I'm Muhammad Idris from Indiana University. So I was tasked to give you a brief morphologic and clinical pathologic picture of trophoblastic neoplasia in testes. So I start with WHO 2004. At that time, there was limited number of trophoblastic neoplasia understanding. So choriocarcinoma was the flagship entity there. Trophoblastic neoplasm, other than choriocarcinoma, included monophasic choriocarcinoma that we removed in 2016 because we knew that it's a similar morphology spectrum as of choriocarcinoma with same prognosis as choriocarcinoma. There was one other entity that was placental site trophoblastic tumor. It's well known in gestational neoplasm in females, but it was new in pathology of the men's neoplasia. So in WHO 2016, choriocarcinoma was the flagship entity. There were 3 other entities that were included in that. It was epithelioid trophoblastic tumor, placental site trophoblastic tumor, and cystic trophoblastic tumor. So in WHO 2022, there was no change, and all these entities still exist there. So I know that Dr. Luyenga have already described this thing. So this is a trophoblastic spectrum includes in the type 2 types of GCNIS-derived tumors. It's a non-semitomatous germ cell tumor spectrum. So, and from there, it can differentiate into different subtypes. Choriocarcinoma, as I said, it's the most common of these trophoblastic neoplasia, and it's the most aggressive one. It differentiates to resemble a trophoblastic cell of the extraembryonic chorionic type and give rise to cytotrophoblasts, intermediate type trophoblasts, and syncytial trophoblasts. So it characteristically induces a biphasic appearance on microscopy. It's mostly associated with elevated beta HCG, sometimes in hundreds of thousands of international units. Typically, it has hemorrhagic background on gross and also on microscopy. It's among all the germ cell tumor, it's least common when it's in pure form. In one meta-analysis, it's only 0.3% of all the germ cell tumors, but in mixed germ cell tumor, it can be from 6 to 18%, depending on different reports. So it has a unique characteristic that it can spread through the blood vessels as well as through the lymph nodes. It has worse prognosis among all the germ cell tumors. One unique entity that we often hear from the female counterpart that there is a choriocarcinoma syndrome. That means there's extensive bleeding in the viscera because of the volume overload of these tumors. So it's widely metastasis. It consumes all the fibrinogen and other coagulating factors and cause massive bleeding. So that can decompensate the patient quickly, and it happens in male counterparts also. The tumor is highly chemosensitive to platinum-based therapy, and it's usually a combination chemotherapy is given in these cases. Morphologically, you can see this is a very hemorrhagic tumor. You can see a rim of the tumor that is probably grayish tan to whitish. There are multiple nodules in this picture. You can see it's still hemorrhagic, and some of the tumor is viable here. Microscopically, a unique biphasic appearance is noticed in almost all the tumors, except few examples. So biphasic means that it has syncytial trophoblasts. Those are multiple nuclei containing cells, and a mononuclear type of variety of cells. Those are the cytotrophoblasts and the intermediate type trophoblasts. These cells of syncytial trophoblast type specifically show these lacuna or holes within the cells, and then these holes can also get red blood cell in that. So it tries to make some vascular structures there. Extremely high mitotic rate in the mononuclear component. Syncytial trophoblasts are terminally differentiated, so they don't show any mitotic figures. The tumor is usually associated with high beta HCG, and can be expressed on IHC, and we can also stain it with GATA3 that is uniquely positive in all the trophoblastic cells. EGFR expression has been shown on the tumor, and in more than 50% of the cases. So this is a classic morphology where you can see there's a vastly hemorrhagic background and then interspersed cells of two types. Here I can say that syncytial trophoblasts are not very much represented. Well, you can see in the center right here, you have a large cell with the lacuna in there. Rest of it, this is taken from the edge of the tumor. And I usually recommend when there is a hemorrhagic tumor that appears to be a choriocarcinoma, you please take samples from the edge of the tumor, because that's a place where you'll find the viable tumor. This is classic picture where you can see a mixture of syncytial trophoblastic tumors, which are more eosinophilic cells, and then the trophoblast in the background. You can see these vascular lakes. These are lined by these trophoblastic cells, often capped by the syncytial trophoblastic cells, and sometimes protrude into the lumen of the vessels. On the right-hand side, you can see a mixture of syncytial trophoblasts, large cells with eosinophilic cytoplasm, multinucleated, and some of the cells showing these lacuna in the cells, some showing even red blood cells there. I put a HCG immunohistochemistry slide down here, and you can see that it's characteristically staining the syncytial trophoblast cells in an intense way as compared to the background trophoblasts. Another morphology that we see often in retroperitoneum in metastases or recurrences, where you don't see this unique biphasic component. You may see diffuse distribution of these trophoblastic cells. Most of them are cytotrophoblasts, and rare syncytial trophoblasts. But you will find that these are aggressive appearing tumor, very pleomorphic appearing, hyperchromatic, and you can point out a lot of mitotic figures. There's a necrosis also. One unique finding is that there is this hyalinized material, fibrinoid eosinophilic material in those cases. So this is for all practical purposes are monophasic choriocarcinoma. We discourage to use this terminology because it confuses physicians also how to treat this thing. So just type it as a choriocarcinoma. It's one of the spectrum of it. Often we get biopsies from the retroperitoneum after the treatment, and you can see there, these are highly pleomorphic cells. Some of them I can classify them as a syncytial trophoblast because I can see there are lacuna in there. In the background, there is no hemorrhagic background. This is a post-chemotherapy typical appearance that you may have fibrotic background with the inflammation, and you can see this. There is some pigment that is present also in the post-chemotherapy patient. So, but in any way, you can do IHC on these, and these are strongly positive for HCG. So what other tumors can mimic these tumors? So mostly people can be confused when they find increased beta HCG. So they feel like, okay, they may be missing some choriocarcinoma in primary testis tumor or even in retroperitoneal lymph node dissections. So it happens that the seminoma can contain an abundant amount of syncytial trophoblasts without any cytotrophoblasts or intermediate type cells. And these syncytial trophoblasts can secrete a lot of beta HCG and often convince us to submit more sections because I'm afraid that if I missed choriocarcinoma, it will have a worse prognosis. So since seminoma can show syncytial trophoblasts, and similarly embryonal carcinoma can also show syncytial trophoblasts, and sometimes difficult to pick those cases where you see embryonal carcinoma mixing with a lot of syncytial trophoblasts. It really mimics a choriocarcinoma. So immunohistochemical stains resolve that issue as well. Another peculiar arrangement in embryonal carcinoma, which we refer as applique pattern, often comes into picture where we see that there are syncytial trophoblasts at the margin of the nodule. However, these are not the real syncytial trophoblasts. These are basically degenerating embryonal carcinoma cells that line the edge of the nodule or the edge of the necrosis. And then, as I already mentioned, we don't use term monophasic choriocarcinoma. Other tumors with similar morphologies can be epithelial trophoblastic tumor and PSTT. And then there are some unclassified entities that we occasionally see, but I will not mention those here because there's a lot of work to be done to classify those at this point. So as I mentioned that these seminomas can produce beta HCG, there's a recent paper by Felix Bremer's group. They demonstrate that these seminomas actually have the same genomic profile as regular seminomas, but they have increased or elevated HCG in there. So they recommended that for these type of cases where beta HCG is increased, we should extensively sample the tumor because there's definitely a portion of syncytial trophoblastic cells that are secreting this excess beta HCG. Often I see that the beta HCG is darkly staining everything because if it's elevated, it will stain everything because it's present in the serum. So I used sometimes cytokeratin, the broad spectrum, and it highlights the syncytial trophoblasts very well. All right, so these are a few examples. This is embryonal carcinoma with interspersed syncytial trophoblasts. This has a hemorrhagic background. At low power, it looked like choriocarcinoma, but immunostains were positive for OCT4 and CD30. Another area where you have abundant syncytial trophoblastic cells and few nodules of embryonal carcinoma. On the right-hand side, you can see that there are these smudged atypical appearing syncytial trophoblastic cells here at the margin, which are darkly staining, and also at the edge of the necrosis. So these are basically degenerating embryonal carcinoma cells mimicking as syncytial trophoblasts. So be careful about that. If you are in doubt, just do immunohistochemical stains. So as I said, it's a very aggressive tumor. If it's pure or more than 50% of the remaining tumor, the prognosis is similar. It's usually associated with very high level of HCG, and high level of HCG is associated with unfavorable outcome. Combination chemotherapy is usually applied along with the cisplatin-based therapy. And in advanced cases where metastasis or recurrence is occurring, 3-year survival rate is limited to 20% only. So another approach that the physician usually uses high dose chemotherapy and stem cell support. It has been accepted widely here in the United States, but it's present only in limited centers, but it can achieve cure sometimes. The next entity in general is non-choriocarcinomatous tumors of the testes. It have these 3 entities in it: CTT, ETT, and PSTT, as I already explained. Generally, these tumors are post-chemotherapy related, but not always. They can be present in primary testicular tumor. They are less aggressive than choriocarcinoma. Surgical excision is best if possible, and it has poor chemosensitivity, especially when they recur or present in metastasis. So cystic trophoblastic tumor, the tumor that was defined in 2001 by Liang Cheng and all at Indiana University. They saw this cystic proliferation of degenerated appearing trophoblastic cells. And the proposed pathogenesis was that these are derived from treated choriocarcinoma or spontaneous regression of choriocarcinoma. Initially, it was thought that this is a byproduct of chemotherapy, but we now know that these tumors can also occur in testes without any chemotherapy. So this is probably a phenomenon that is related to degeneration of choriocarcinoma or regression of choriocarcinoma. This is the typical morphology. You can see large cysts lined by these degenerated or smudged cells, and you can see abundant lacunae within the cytoplasm of these cells. Very rare mitotic figures are found in these cases. Sometimes you will see that there are these clusters of cells in the stroma, but if you pay attention, these are all trying to make these degenerative appearance with cystic formation. So these are all mostly connected, and they are usually making a localized kind of nodules. Here is an example of a solid cluster where there are abundant lacunae in the center, and then you can see this hyaline globular material also within the cells. And they may be cystic also in those, and you see the cyst is developing here. So the center will degenerate and the cyst will develop ultimately. So these are the few of the characteristics of these tumors. So they're always cystic, and almost 100% of the time they are associated with teratoma. They have well circumscribed growth pattern. HCG immunoreactivity is there, but it's not as remarkable as choriocarcinoma, but they can stay in with HCG. They're multifocal in 70 to 80% of the time. There may be a prominent fibrinoid change, as I mentioned, with those eosinophilic globules. Mitotic figures are rare, as we have way more experience now with these tumors. I think it's way more common than we previously expected, because these are usually merged with teratoma, and it's not easy to identify because small clusters of these tumors can exist in almost a lot of 10 to 15% of the cases in retroperitoneum in my experience. So originally, this was proposed that the CTT should be classified as a trophoblastic tumor, and there should be a note in the report that this is not a choriocarcinoma or anything that will raise suspicion of being more aggressive. So I still put a note in there and say testicular CTT it has a prognosis similar to teratoma, and it doesn't need any further treatment except the excision. Epithelial trophoblastic tumor is another tumor that we have a little bit more experience. In recent years, I had multiple cases shown to me in last 3-4 years after we published one of the biggest series in 2017. So they are thought to originate from intermediate trophoblastic cells of the chorionic leaf. That's a smooth portion of the chorion, and it have a typical squamoid monophasic trophoblastic appearance. And they make epithelioid nests with abundant eosinophilic cytoplasm. They typically lack the biphasic pattern of choriocarcinoma. They have prominent cell boundaries. They have intracytoplasmic, extracytoplasmic eosinophilic fibrinoid and globular material that we saw in CTT as well. Generally infiltrative pattern and cellular polymorphism is remarkable, and you can easily identify a mitotic figure in these cases. Here's a case which had predominantly ETT, and you can see that it could be associated with necrosis. There's a fibrous stroma in the background, and at high power view, you can see these are the generally monomorphic tumor cells of trophoblastic types. that have hyperchromasia and abundant pleomorphism in this example. Other areas can show you this eosinophilic deposit within the cells and outside of the cells. And you can also pinpoint few of the mitotic figures in this example. One peculiar pattern is that around the blood vessel, there is a enhanced deposition of this fibrinoid material. So that's very unique to the ETT that we usually see. Here it's depicted that this can be a solid neoplasm, but sometimes it can often create some cystic areas. Inhibin is usually positive, but weakly. But P63 is positive in most of the tumor cells because they are derived from the intermediate type of chorionic Leaf cells. So those cells are P63 positive. So placental site trophoblastic tumor is the next entity that we will discuss. It is also derived from the intermediate trophoblastic cells, but they resemble implantation site cells. So usually mononucleated, and they are more diffusely infiltrated with a fibrinous to edematous stroma also. And characteristically, these invade into the vascular wall and often surround the lumen of the vessel. So these are the implantation site trophoblast, and they're doing what they're supposed to do. They infiltrate vessels and make connections there. Other thing is that they're widely invasive, and you can see in retroperitoneal, all the lymph node boundaries are actually invaded and perforated through, and usually these tumors are present in the fat, also in small cell clusters. HPL is diffusely and strongly positive in these tumors, and this should be utilized in terms of clarifying it from the ETT. So this is the trophogram labeled as by Dr. Shi in his paper. This is for the gestational type trophoblastic tumors, but I think it plays very well with the testes also. Here it shows that P63 positive is associated with epithelioid trophoblastic tumor, and P63 negativity is related to PSTT. And it's basically two different types of intermediate cells. One is from the implantation site that creates PSTT, and the other one is from the chorionic leaf or the flat chorion, and that develops into ETT. So this is the immunoprofile. So it's very easy to distinguish them. HPL is positive in PSTT, and P63 is positive in ETT. So takeaway points from this presentation is that CTT prognosis is similar to the teratoma. 11% recurrence in teratoma versus 18% in CTT. So we tell physicians that don't do any further treatment. Resection is enough for this. ETT is aggressive and may recur and cause metastasis also. Resection is optimal treatment. It's aggressive, but we feel like that no additional chemotherapy is required in most cases. PSTT is also aggressive, and we have very limited experience with this thing, but resection is recommended in cases that I have seen so far. I haven't seen any recurrence in those cases. So I think we're right where we recommend that there shouldn't be any further treatment in terms of chemotherapy or others. Choriocarcinoma, when it metastasizes or show up in retroperitoneum or other organs, we need additional chemotherapy, and that's where we have to differentiate choriocarcinoma for PSTT and ETT. Usually I use mitotic activity as a marker for that. If the mitotic activity is increasing more than 20%, I will get suspicious that this is a weird spectrum of choriocarcinoma, and I recommend physicians that they should treat this patient further. And now, finally, we have some unclassified or hybrid tumors that we sometimes see. These are rare, but we have encountered them in our practice a few times. And here you can see this is one of the published cases in 2017, I believe, that where we saw that this tumor showing squamoid appearance here is intricately mixing with some glandular type of tumor which shows characteristic of squamoid appearance or trophoblastic appearance. So this was unique for this tumor, and we couldn't put this in any kind of classification here. So this is left as unclassified. It was staining with Glypican-3, so we were thinking it's probably a transition from this yolk sac tumor to the trophoblastic differentiation, but there's no way to prove that we have only 1 or 2 cases of this entity. And with this, I think I am finished with my talk. Thank you very much for the opportunity.
Thank you, Dr. Idris, for your wonderful talk. I think I've been loving the talks from our speakers today. I'm learning so much, and I hope all of you are as well. So our next speaker, Dr. Stephen Smith, is Associate Professor of Pathology and Surgery, serving as Director of Genitourinary and Soft Tissue Pathology at the Virginia Commonwealth University School of Medicine in Richmond, Virginia. Dr. Smith's research interests center on genitourinary and soft tissue neoplasia classification, with particular interest in the intersection of histomorphology, immunohistochemistry, and molecular diagnostics. So Steve's efforts have resulted in approximately 150 peer-reviewed publications and more than 75 textbook chapters, including multiple sections of the WHO classification of tumors. So Steve has given talks in multiple international venues, and I have worked with Steve personally on a day-to-day basis, and it has been a great experience and very gratifying to be still associated with him. Thanks for accepting our invitation, Steve, and we look forward to your presentation.
Thanks so much. Thanks so much, Rohit. I hope you can hear me all right.
Yes.
I have had the distinct honor, and for my education, both pleasure and benefit of having had Dr. Mehra as my senior resident at the University of Michigan, or School of Medicine, or Michigan Medicine as it's now known, many years ago. So much that I learned then and much that I'm learning today. I appreciate the topic of the spectrum of surge path findings post-treatment in metastatic germ cell tumors, including SST. And we'll get to what that SST is coming up in just a second, but not sex cord stromal tumors. Don't worry, we're not going off the rails here. So in terms of the overall plan, there are kind of 3 take-home points that I'd like to make with this. One is just kind of a little bit of commentary on the spectrum of the clinical settings and the specimen types you get, at different points. Again, I said I'd define the SST in a second, and we'll talk about RPLNDs and metastectomies. But I think what's important, and in fact, probably most of the slides here, deals with the nuts and bolts of histologic findings for your reports and your reporting, and then touch on some of the patterns and pitfalls not to miss. Many aspects of Dr. Idris has already touched upon, so that will be an easy one for us. Definitions and spectrum. Well, I would be remiss if I didn't give you the SST. This was actually a prescient inclusion in the topic of the seminar. I don't know if it was Shaunak Rohit or perhaps Samson. The new NCCN really has deleted the word salvage. It's sort of disfavored, and it's important for us to remember that, treatment failures post-chemotherapy in testicular cancer are a very different story than they are in other cancer types, and very different prognosis here. So I think it's useful for our patients to keep that in mind. Now we emphasize second line and subsequent therapy is sort of the terminology, and you'll probably start to hear it popping up in your tumor boards. This describes cases of recurrence in the near term, that is generally less than 2 years after prior chemotherapy, or perhaps non-response to the primary chemotherapy. In this setting, of course, clinical trial favored always by the NCCN, but either conventional dose chemotherapy, a slightly different recipe than standard primary therapy, or that high-dose chemotherapy with autologous stem cell transplantation that was mentioned. And just as a reminder, recurrence later, greater than 2 years after chemotherapy, is quite rare, and surgery is preferred there. And also a reminder that this doesn't apply to, cases, recurrences in the retroperitoneum or elsewhere in a patient who is chemo naive. Okay, this is only after failure of the primary BEP protocol that's often used. Then, a brief thought about the clinical specimen types. And I think this is worth touching on. And I know this first bullet is a little bit off the topic, but I get consult cases about this from time to time. People sending in an RPLND saying, "Oh my goodness, RPLND is such a huge surgery. I can't believe there's no germ cell tumor in this," or what is the story? And it's important to realize that with contemporary experience in nerve-sparing retroperitoneal lymph node dissection in, very capable high-volume hands, this is not the debilitating surgery with the significant fertility, sexual function, and even lymphedema outcomes classically described for this. So this is increasingly contemplated for a subset of early-stage chemo-naive germ cell tumors, especially mixed germ cell tumors, although rarely in certain very localized circumstances, seminomas post-orchiectomy. And the idea here is if this isn't as morbid a procedure as it was 20 years ago, the idea is to identify and remove these micromets, remembering that the recurrence pattern of these localized tumors is very much retroperitoneal there. And if successful, this buys the patient the opportunity to have less imaging and a substantially lower risk for chemotherapy at any point in the future due to removing the most likely landing site for metastatic disease. Also considered in the decision are risk factors that you have control over in your untreated orchiectomy reports, including lymphovascular invasion, a high proportion of embryonal carcinoma, or things like radiologic or biopsy evidence. What they really want me to talk to you about, however, is the rest of this here. And this is post-chemotherapy RPLNDs, where there's been a lot of recent scholarship about different patterns of disease seen and what they mean, pitfalls, etc. This tends to be done for mixed non-seminomatous germ cell tumors. If they're a centimeter sized retroperitoneal lymph node after chemotherapy, or sometimes seminomas, especially if they're large. And in that setting, actually PET-CT becomes relevant. And if they're avid and or biopsy positive, you can get an RPLND in that setting as well. And then, of course, any visceral metastasis post-chemotherapy, chemotherapy is highly effective in germ cell tumors, and very often lung or liver or other sites metastases just sort of melt away during chemotherapy. If there's anything suspicious remaining after that therapy, metastectomy is often performed, although these are distinctly rare specimens, at least at my institution. The last thing I'll quickly mention is post-chemotherapy orchiectomy. As you know, this is almost always done immediately up front, which allows us to classify the tumor and the patient to be staged and risk classified. However, in patients with really high-stage life-threatening metastasis, think brain mets with choriocarcinoma or choriocarcinoma that is bleeding everywhere, sometimes patients have to get sent immediately for chemotherapy. And you can then, at some point later interval, receive a post-chemotherapy orchiectomy. So, the name of the game in terms of the post-chemo RPLND pathologic spectrum is this. Remember that subsequent chemotherapy is driven by your correct identification of viable non-teratomatous component of this metastatic germ cell tumor. Teratoma is considered surgical disease. It is chemo-resistant. It's not very proliferative. And if you look at, for example, meta-analyze the findings of these 4 large series in the bottom right of the slide, what you'll find is if you look at all of these RPLND post-chemo specimens, about half show just necrosis, fibrosis, and xanthoma. Maybe 30–40% show just teratoma only. And about 10 to 20% show a viable non-teratomatous germ cell component. At our institution, I'd say probably slightly over half are just necrosis, probably approaching half are teratoma, and distinctly infrequently is there a viable non-teratomatous germ cell component. So we'll consider each of these in turn for your reports. Necrosis, xanthoma, and fibrosis. Well, I think all of us can very quickly tell what's going on in terms of the necrosis at the center of this lymph node, even at low power. If you look at it, very often you see a coagulative tumor cell necrosis pattern with these ghosts of cells and these scattered nuclei that you can still ascertain in the background just there don't count as as it being viable. This is all dead. This is often surrounded by this fibroxanthomatous and fibroinflammatory cuff around the tumor. From time to time, looking at the xanthoma, well, you might look at this and think, oh goodness, is there any, say, metastatic seminoma hiding in that? The bottom line is very rarely is this a big enough problem to necessarily need immunostains due to the fact that xanthoma tends to have this foamy, non-clear cytoplasm. But if you ever need to do it, certainly OCT4 will highlight entrapped embryonal carcinoma or seminoma in this setting. About that fibrosis, turns out this is an interesting story and one of my favorite things actually as a pathologist in this area. It turns out that a lot of this fibrosis is likely derived from either metastatic teratomatous stromal elements that are left behind and or a post-therapy chemo-resistant quiescent ultra low-grade hypocellular spindle cell or sarcomatoid pattern of yolk sac tumor. And this has been proven to be neoplastic through it showing isochromosome 12p and 12p gains by fish. In fact, with Dr. Chang and the Indiana group's seminal paper in this area demonstrating it by fish and other molecular means for nodules like those depicted just here. So I think in general, if you're looking like a case like this recent one, this isn't the sort of thing that I might go and accidentally diagnose as, viable yolk sac tumor or something else here. This almost looks like the regressed germ cell tumor scar, vascularized with a little hemosiderosis, et cetera, that we sometimes see in orchiectomies. But this can get a little bit more complicated, a little bit more cellular, some smudgy, degenerated cells, etc. And it's important because overinterpretation of this, say if you do a keratin on it, as viable yolk sac tumor might lead to overtreatment for patients. So it's worth considering and making sure to label this as fibrosis and not to call it as viable yolk sac tumor. And sometimes, depending upon what's in your report, include a phone call. Make sure to bring it up at tumor board and ensure understanding here. By the way, it can also be glypican-3 positive too. But, a cardinal rule in pathology presentations is never admit to ever phoning a friend about a case. Well, of course I phone a friend about a case, and this is in particular one that I sent for an additional extramural expert opinion. There was, yes, a lot of smudgy background here, some very hyperchromatic cells in this fibrotic area, and some unusual looking glandular and perhaps cystic elements here. I was quite concerned. I was very reassured, by the way, when there were practically no mitoses and the Ki67 proliferative index was very low. And I was reassured also when, when the additional opinion came in, sharing my assessment that this was ultra low, spindle cell yolk sac plus some post-treatment teratoma and cystic trophoblastic tumor. Teratoma, well, this is one that, very often we can spot instantly looking at the slide in the tray with these large cystic areas. You can see that there's a teratoma stromal component, different lineages of epithelia in the background here. And it can also show some of that xanthomatous change, adjacent to teratomatous element, this being a chondroid differentiation just here. Again, perhaps this is where a prior non-teratomatous component was completely necrotic. In this setting, I always recommend everyone be very careful with sampling deepers. There can be calcifications in the system, in these sections. It can shrink. You don't want to sign this kind of case out missing large areas of the section of this. So do deepers, resample, etc. Don't allow your gross room, your trainees, your pathologist assistant colleagues to just take a single representative section of a positive lymph node. This is one where we really want to be certain there's nothing there. And a reminder also that in these teratomas, atypia is allowed and expected. Why is it worth addressing that? Well, because there is the issue of teratoma with somatic type malignancy, and this is a teratoma that has a distinct component resembling, malignancies as arise in other mature organs and tissues. Most of the time, this happens with teratomas, and as a reminder, this has to be expansile and infiltrative, not just admixed foci, okay? And according to the new WHO, at least 5 millimeters in size. Also, there's some recent scholarship strongly relating these, actually the sarcomatous forms of this, to sarcomatoid patterns of yolk sac tumors. So perhaps in future classifications, we'll see reconsideration of just the teratoma width terminology for this. If you look at it, this is an example of obviously a large expansile process. Sometimes I sign out PEDS path and it reminds me of maybe a treated neuroblastoma, for example, here. And this was the best example I could find in my files where I could try to portray it to you as almost looking like a small round cell tumor. Most of the time, there's more like primitive neuroepithelial elements here. Either way, these days we label them as embryonic type neuroectodermal tumors to avoid the PNET of yore that might get accidentally conflated with Ewing sarcoma. And this terminology has been adopted in the WHO. Just one more quick example of this retroperitoneal mass. And I thought I'd just remind everyone to be careful about this, because in late recurrences like this one, the issue of margins actually can come into play. And as you can see here, it was hard after this gross exam to interpret that in this case. Again, a large expansile malignant mass. You can see that there's necrosis, etc. here. At high power, the spindle cell process, lots of mitoses, etc. But you can appreciate that there are areas of rhabdomyoblastic differentiation, expression of myogen and MyoD1 and Desmond, with this representing a somatic type malignancy with embryonic rhabdomyosarcoma pattern. Just make certain that there's lots of necrosis and mitoses, etc. For the sake of a pitfall we'll touch base on in just a moment at the end. Viable non-teratomatous germ cell tumors, something that we're a little bit more comfortable with. You can have cases like this, which represent OCT4 positive, keratin positive, embryonal carcinoma. In fact, in this case, it's starting to have a little bit of that. Could it be a monophasic choreo? In fact, it was GATA3 and HCG negative, this being probably an aspect of that pattern of degenerative cells at the periphery Dr. Idri is mentioning. For the full spectrum of these, certainly we've covered them here today. I recommend everyone consider Dr. Cowles and Dr. Albright's recent review papers touching on this area. But just as a quick reminder of the patterns that might trigger additional chemo, of course, choreo, of course, conventional solid yolk sac tumor, which can, by the way, simulate seminoma as well. A more controversial one is glandular yolk sac tumor, with some experts saying that it usually doesn't respond to treatment. My oncologists tend to want to know about it and consider it. But this is a very nice differential diagnosis in Dr. Albright's review, juxtaposing glandular yolk sac tumor in panel D to a somatic type GI adenocarcinoma arising in a teratoma in panel C. Those that are managed surgically include cystic trophoblastic tumor. I won't belabor because we've just touched on it. Rhabdomyomatous tumor, which is the very low-grade counterpart of that embryonal rhabdo pattern I just touched on. And sarcomatoid yolk sac tumor, which is itself a more cellular version of those fibrotic nodules we mentioned at the beginning. Just another example of cystic trophoblastic tumor for your occipital cortex. Rhabdomyomatous tumor, again, being managed surgically, well-differentiated skeletal muscle pattern just there. And finally, the sarcomatoid yolk sac tumor, all from Dr. Albright's review of a couple of years ago. And as one last thought, consider, anytime you encounter one of these specimens referencing the College of American Pathologists Synoptic, it isn't required for accreditation, but I do like it because it's a good reminder of all the recommended reporting elements for rare tumors. And with that, I'll express my appreciation for the opportunity to speak.
Thank you, Dr. Smith. That was an excellent overview. Uh, and I just want to remind everybody that if you have questions, please put them in the Q&A box. And once we finish with our next speaker, we'll direct your question to the speakers. So our next speaker is Dr. David Nicol. He's the Chief of Surgery and Professor of Surgical Oncology at the Royal Marsden Hospital and Institute of Cancer Research in London. Originally trained in Australia and Canada, he was previously Director of Urology and Professor of Surgery at the Princess Alexandra Hospital and University of Queensland in Brisbane, Australia, prior to moving to the UK. Importantly, in 2019, he became a member of the European Association of Urology Testicular Cancer Guidelines Panel, which I'm sure many of you reference. And he was appointed chairman of this panel in 2022. This panel provides an annually updated guidelines on the management of testicular cancer, which is freely accessible as a web-based publication. And today he's kindly agreed to join us and talk to us about the clinical management of advanced and metastatic germ cell tumors. So thank you, Dr. Nicol, for participating, and I'll let you start your talk.
All right. Well, thank you very much, bothly, for the kind invitation and also the introduction. So I'll be providing an opinion from across the Atlantic, where there are some subtle differences in practice to the US, but most of the aspects of practice management are quite similar. In keeping with my brief, I will basically be addressing stage 2 and stage 3 disease. Now, the key point with stage 2 and stage 3 is with stage 2 disease, this is nodal spread to the retroperitoneal lymph nodes as a specific feature, whereas stage 3 is where it's extended beyond the primary metastatic site, i.e. the para-aortic lymph nodes, to involve lymph nodes beyond that area and visceral, bone, and cerebral metastases. Just as a beginning, orchiectomy will cure most. Now, by most, that's really just a little over 50% of testicular tumors alone. At presentation, 70% of patients have stage 1 disease, with obviously others being metastatic at that juncture. And of these, 20 to 30% of patients will go on to develop relapse reflecting occult metastases. The operation that's performed involves removal of the testicle and also the spermatic cord up to the inguinal ring, and it's commonly referred by urologists as a radical orchiectomy. This term, however, was one that originally evolved in the 1930s and 40s with the realization of the high mortality associated with this disease. And at that stage, the additional treatment was felt to be surgical, where addressing potential disease or existing disease within the lymph nodes would be treated at the time of initial surgery. The procedure, therefore, was a very major undertaking and clearly did benefit a small number of patients, principally those that had small volume occult metastases within their lymph nodes. And so this was a modest step to orchiectomy alone. The next change occurred in the 1950s, where radiotherapy became more widely available. And this did improve the outlook for patients with metastatic disease, but unfortunately, this was essentially limited to those with seminoma. It became clear that irradiation did not provide any additional survival benefit to patients with non-seminomatous germ cell tumors. And so up to this point, the treatment with an orchidectomy and lymphadenectomy remained for patients with non-seminomatous germ cell tumor, but radiotherapy was universally introduced both to treat metastatic disease and to address potential occult metastases. Systemic chemotherapy began to drift into clinical practice in many areas of urology in the late 50s and 60s, with agents such as cyclophosphamide and other cytotoxic drugs. And these were tried in many diseases with modest success occurring in terms of initial response with testicular cancer. Unfortunately, with the agents available at that stage, relapse, unfortunately, was almost invariable, and a sustained response occurred in less than 10% of patients. And so really into the 60s and early 70s, testicular cancer for patients with disseminated non-seminomatous germ cell tumor was extremely poor. An almost revolutionary event occurred when cisplatin was identified as a potential agent that would be effective with this disease. It was, in fact, a very old compound, first identified by an Italian chemist in 1845, and identified the molecular structure. At that stage, there was no real desire to seek a use for it, and that remained the situation for over 100 years. As with many things, compounds generated new interest and began a little journey being looked at whether it had antibiotic properties, but again, this did not prove to be the case. But in vitro work demonstrated that it had quite a profound effect on tumors, and the initial publication on this related to sarcomas in mice, which exhibited a dramatic response to this single drug. As a consequence, oncologists became very enthusiastic about its potential in tumors that otherwise were relatively chemoresistant. And thus, studies were undertaken in the early 70s with a landmark publication appearing in 1977 by Drs. Einhorn and Donahue from Indiana, in which they described the use of the combination of cisplatin, vinblastine, and bleomycin in a combination, and the successful outcome that occurred in a vast majority of patients with this treatment. Consequently, it was licensed for use by the FDA in 1978 and in Europe in 1979. And so the modern era of treatment of testicular cancer was really transformed effectively in the early 1980s as these agents were widely used to treat testicular cancer. So reflecting back on these various agents, we now see with advanced disease that chemotherapy is now the treatment applies to most, but not all patients. Radiotherapy has become increasingly historical and now is relatively rarely used and only in seminoma. In our practice, it's largely restricted to older patients who may have issues with systemic therapy and low volume stage 2 disease as a somewhat quirky UK practice and not undertaken in the United States or the rest of Europe. Finally, surgery, which actually still remains, but its indications are now quite precise. This is predominantly retroperitoneal, removing the retroperitoneal lymph nodes, which may contain large metastatic deposits, although obviously other viscera and lymph nodes beyond the abdomen may also require surgical resection as a strategy for removal of residual masses after chemotherapy. As Dr. Smith outlined, it's increasingly becoming a primary intervention, and seminoma is now entering the field where this is being considered. And it's also an important component of late recurrence, as these tumors are essentially resistant to other forms of treatment, although chemotherapy and radiotherapy may be used, but are probably best regarded as somewhat palliative in nature in this setting. So just looking at the outcomes and how they've been transformed. So overall 5-year survival with testicular cancer is in excess of 90%. Most patients are either good or intermediate prognosis, but there still remains a relatively poor prognosis group. But even in this, long-term and durable survival is present up to 70% of cases. And this needs to be contrasted with the less than 10% survival in patients with metastatic disease before the introduction of cisplatin-based chemotherapy. So what about the treatment itself? What's done? Well, the mainstay of treatment with systemic chemotherapy is now these agents. Etoposide has been inserted as a less toxic option, and so bleomycin, etoposide, and cisplatin is the standard routine. In Germany, it's referred to as PEB, and it's also at times described as PVB, as etoposide was initially known by a proprietary name of VP16 or vepicide. It's administered in 21-day cycles where people receive cisplatin and etoposide as an intravenous preparation from days 1 to 5, with bleomycin being administered on a weekly basis on days 1, 8, and 15. Based on risk stratification, the number of cycles of bleomycin may vary. With good and intermediate prognosis, and this is both seminoma and non-seminoma, 3 cycles of BEP is regarded as the standard of care. Alternatives may be considered at certain times, and one particularly is whether bleomycin, which has pulmonary toxicity, can be omitted. And so in patients where there are issues with bleomycin and lung toxicity, a slightly longer regimen of just etoposide and cisplatin can be used, but for 4 cycles. Alternatively, substitution of ifosfamide, which is a similar agent to cyclophosphamide, but again less toxic in patients who are over 40, smoker, or have or develop respiratory problems during treatment. The poor prognosis group is a term that's only really applied to non-seminomatous germ cell tumors. No seminoma actually fits the criteria of poor prognosis. And these are patients with mediastinal primary, non-pulmonary visceral metastasis, and also elevated markers at the time chemotherapy commences. These patients are treated with an additional cycle of BEP. It's probably the most common strategy employed, although there are an array of, shall I call, institutional high-dose regimens that are employed, often by large cancer centers who undertook studies on these particular combinations as things unfolded during the 80s and 90s. None of these institutional preferences, however, have been shown to have any significant advantage over the standard combination used for 4 cycles. Clearly, these drugs do come at a price, and this results in both short-term toxicity, for example, the emetic effect of these agents, although this is very adequately addressed now by some of the newer drugs that are available. But ototoxicity, neurotoxicity are particular concerns with cisplatin, myelotoxicity with etoposide, and pneumonitis with bleomycin. Most of these are short-lived, but a number, particularly ototoxicity, can persist. And in fact, in men, if they're closely studied more than 10 years after they've received cisplatin, will still exhibit what an audiologist would term significant hearing loss in 60%. Again, I won't go into detail with relapse and salvage treatments, but these are patients that recur within 2 years of their initial treatment, and essentially reflects chemo-resistant tumor lines, and thus strategies with more potent and also toxic chemotherapy may be required, and TIP is probably the most frequently used, although there are other combinations. This type of treatment becomes more problematic as essentially stem cell support is required, and thus the support of a bone marrow transplant unit is required to administer adequate doses of drugs that may be effective to achieve a relapse in this difficult to treat group. Finally, surgery, which is my principal area of clinical practice, and clearly it has a very defined role for the removal of post-chemotherapy masses with non-seminomatous germ cell tumors. Resection of all residual masses, and that's defined as a mass greater than 1 centimeter, once if markers have normalized or low or stable elevation, or where there's been an increasing mass and normalization of markers. And at times, chemotherapy may be abandoned after 2 cycles to proceed immediately to surgery in cases like this, where this entire mass is post-pubertal teratoma and has progressed whilst on chemotherapy and marker negative. As I mentioned, this involves retroperitoneal lymph node dissection as well as other sites. And going back into the pathology, it's important to highlight there can be discordance between sites. And so pulmonary metastases may exhibit teratoma, whereas the lymph nodes have necrosis and fibrosis only. So clinicians can't base or presume that other sites harbor the same disease as an initial site of resection. As mentioned in Dr. Smith's talk, the prime aim is to try and remove post-pubertal teratoma, which does not respond to chemotherapy, although necrosis and fibrosis and 10% active disease, which is actually the UK figure for post-chemotherapy lymph node dissection on a national survey that was taken a number of years ago. Surgery is increasingly considered in low volume stage 2 disease. And there are two potential scenarios. One is a patient who has a non-seminomatous germ cell tumor who is marker negative but has enlarged lymph nodes. Many of these will comprise post-pubertal teratoma, which is chemo-resistant. And thus, if this is the case, the patient avoids unnecessary toxicity of 3 cycles of BEP. Similarly, in PNET and dedifferentiated teratoma, which are both chemo-resistant, if the tumor is surgically resectable, this should be undertaken as an initial event rather than considering conventional chemotherapy. Furthermore, with radiological staging, 10% will be downstage pathologically, and thus they will avoid, again, unnecessary toxic treatment. If active disease is present in the retroperitoneum, 30% will relapse without additional treatment, 20% within the abdominal self, and 10% distantly. And in these, adjuvant BEP or 1 or 2 cycles may be considered, which will reduce this risk of relapse down to less than 5%. An area of considerable interest and activity, including a large study in the US, looking at stage 2 seminoma. And as mentioned, the morbidity of this procedure has been reduced by the use of minimally invasive surgical techniques, remembering this is essentially normal tissue they're operating on. And where primary RPLND is performed using a unilateral template, 70 to 90% of patients will be cured with no additional treatment. Those in whom it does recur are then always salvaged by conventional chemotherapy regimens. This strategy, whilst it does accept an element of relapse, enables the avoidance of BEP in the vast majority of patients, and that's the principal factor driving this change in algorithm. It's also an interesting space for pathologists because there are 3 patterns of nodal disease that we see. One is where the node is quite enlarged, but comprises a very small percentage of seminoma, with the vast bulk of it being this granulomatous inflammation. There are 2 others. One is where the lymph node contains or is fully replaced, but there's no breaching of the capsule. And the third is where the tumor extends beyond the capsule. Now, by convention, that's recorded as a positive surgical margin, whereas in fact, there's no margin. It's merely tumor prolapsing out of the lymph node. And so the terminology of this needs to be resolved for consistency if we're going to be reporting data. And finally, the stromal tumors and malignant paratesticular tumors are also those that may need surgery as an initial event rather than systemic treatment. The goals of treatment over the last decades have been more to improve and maintain cure rates rather than any dramatic change. And our emphasis now is on reducing the late toxicity and morbidity related to the treatments, and this is consideration of adjuvant treatment in high-risk stage 1, removing radiotherapy, and where possible, reducing the number of chemotherapy cycles or the need to rely on chemotherapy. A further point of caution is that the current prognosis may be a potential threat to patients, i.e. there's a level of complacency in society as outcomes generally are fairly good. It's a rare disease and mistakes can be made, and pathology is one where it needs the services of a specialist uropathologist rather than a general pathologist due to the significant change in diagnosis that we experience when it's referred from a general hospital to a cancer centre. Mistakes made by oncologists are that they may use unnecessary chemotherapy or inadequate regimens, and surgery. The faults are lack of referral for consideration of removal of small masses, and in the occasional operator, an inadequate resection, which sets the patient up for relapse and often a poor prognosis. A philosophy within the UK is that primary, intermediate, or poor prognosis disease, relapse metastatic disease, including late recurrence, and all surgery except orchidectomy should only be performed at high volume centers or collaboration or within a collaborative group with tumor board discussions. So finally, I'd like to thank for the opportunity to speak this afternoon and just highlight the journey that has occurred in transforming a disease that's been a young man's tragedy as a model for curative neoplasm. Thank you.
Thank you, Dr. Nicole. That was a great talk. And I see some questions coming through in the Q&A box, and we'll start directing them to our speakers. I'll start with Dr. Luenga. Dr. Luenga, you talked about the different types of germ cell tumors, and many of our colleagues may have missed that early portion because they joined late. And I just wanted to ask you, do you think that there may be some overlap between some of the types of germ cell tumors as you described, let's say between type 2 and type 3, or are these fairly clean categories as you see it?
Yeah, I think you always hope from this perspective that those are clean categories. I think that's clear from both the clinical as well as developmental point of view. There are those overlapping categories. I think both for the type 1 as well as the type 2 and the type 2 and 3. There are now reports related to the more traditional seminomas versus spherocytic tumor, that they have kind of combined characteristics related, and that's also for the type 1 and the type 2. But overall, that's mainly related to age as well as chromosomal abnormalities, and those have to be taken in considerations about further differentiation and optimization of the classification. But for sure, those are relative minor numbers compared to the total numbers of these tumors.
Thank you, Dr. Luenga. So we have a question in the chat box for Dr. Nicole. If you can please help address. So our attendee wants to know, what is the radiological definition of response to chemotherapy in the context of a metastatic retroperitoneal mass? Or what are the criteria for you to perform a RP-LND post-chemotherapy?
Well, I guess the textbook guideline answer is a residual mass with its greatest dimension more than a centimeter. However, it needs to be contextualized in terms of the size of the mass. And so if someone has a 15 centimeter mass that comes down to 3 centimeters at the completion of chemotherapy, my inclination would be to continue to monitor that, because it's the percentage increase, and that mass may well continue to regress over time. The patient may avoid surgery. Conversely, if someone's got a 2 centimeter mass that comes down to a 9 or 8 millimeter mass, I'd be anxious leaving that there. So there needs to be contextualization of the clinical features, although the broad guideline point is 1 centimeter in maximum diameter. So that's it. The cases that are profoundly difficult and very challenging are the pure embryonal carcinoma if they have large volume disease, because they are very much like seminoma in terms of their sort of surgical phenotype. They are very densely fibrotic. They frequently are just necrosis and fibrosis, and so the actual residual disease in them is low. They don't have teratoma, and you're taking a very morbid procedure. And so I'm just cautious in looking at someone who's got a pure embryonal that's large and is reduced. So you tend to be a little bit more cautious with that as well. So there are, I guess, subjective parameters that drive the decision for surgery.
So just as a follow-up to that, what might be your preferred approach for pure embryonal carcinoma?
I would tend to sit and watch for a while with that, because it may be the same as seminoma in that continued, as you all know, the seminoma will reduce down, it's PET negative, and it'll just shrink away, but it takes 12 to 18 months to shrink away. So I tend to watch it for longer. A lot of people write and advocate that surgery should be proceeded with immediately. I'm not such a fan of that because often the patients tolerate surgery better if you give them a 6 to 8 week break. And quite frequently, where there's been large reduction mass, we'll often sit tight and repeat a CT in 3 months' time. So we don't practice this level of urgency that you might gather that people advocate or appear in some guideline documents.
Thank you.
So I have a question for Dr. Idris, and this kind of comes down to a recent discussion at Tumor Board, and it's one of the things that you highlighted is occasionally you may get a beta HCG elevation without having choriocarcinoma. And just for the many trainees who may be on the call, could you talk about maybe some correlations with serum beta HCG levels and what you typically see for choriocarcinoma? And what is your experience with beta HCG levels, let's say for seminoma with syncytial trophoblast type cells?
So the first thing that I look at beta HCG is if it's in thousands. So I will just assume that there is choriocarcinoma. So I'll go back to the specimen, I'll submit more. That's what it is. I've seen cases of seminoma with syncytial trophoblast up to 800 or 900. So that's acceptable. I will still look for if it's highly elevated and it stays there for some time. I feel like there may be some choriocarcinoma that is not sampled. But if after enough sampling you cannot find it, I think you have to agree that, okay, this is because of syncytial trophoblast. So it's so if you feel that this is in thousands, just assume that there is choriocarcinoma somewhere. Below that, I will accept it as this may be secreted by syncytial trophoblast.
I mean, that's a very good point because patients should have their head scanned if they've got an HCG that's very high as well, because you can have occult brain metastases as well if you can't explain it. Because of choriocarcinoma can have hematogenious spread as an early event.
Yeah.
Thank you. Yeah. So I have a question for Dr. Smith. You very nicely highlighted the low-grade spindle cell proliferation dilemma which we can face. And what strategy do you recommend on a day-to-day basis to perhaps distinguish or separate out a low-grade, truly fibrous spindle cell proliferation from a possible very bland yolk sac tumor like which you might have which you have highlighted? And also in your experience and what do you envisage use of I12P testing? Is there any use in your workup of metastatic germ cell tumors?
Most definitely. I'll answer the second question first because the first one I have half a notion to refer straight to Dr. Idris, although I'll give you my take on it.
Okay.
I12P has, in the metastatic setting, been predominantly of interest in cases of mysterious retroperitoneal prominent metastases of uncertain primary. There are probably 10 or 12 cases in the past decade where we've had individuals who were younger males who had strange unexplained metastases and that did not respond to standard chemotherapy as directed for their histology. And in a number of them, I suppose because I'm a bone and soft tissue pathologist, I'm less scared of opening up the CT scans and looking at them myself than many. And I look at them, I'm like, wow, this is a 47-year-old guy. He's too young to have X, and his retroperitoneum is just loaded. To me, that's germ cell tumor until proven otherwise. And sometimes, especially in the age of minimally invasive biopsies, you might get like an aspirate from a supraclavicular node or other areas that don't speak to metastatic germ cell oriented people. And in that setting, The 12P fish, it can be very useful, and we've used that to prove the origin of it. The problem is, once that's proved, and it's useful in terms of understanding the disease and the disease process, and perhaps avoiding chemotherapy for purposes, inappropriate chemotherapy for purposes of other drugs, there's not an awful lot that's very clear that can be done at that point. Although we've had a number of cases that we've sent for comprehensive genomic profiling and other kind of efforts to try to identify targets. The take-home message is surgical management of that as much as is possible, technically possible and safe, tends to be the favored approach for that. So that's where we like the ISO 12P. The question about when does fibrosis slash low-grade spindle cell yolk sac start to make me worried? The answer is when it becomes proliferative and cellular. I know it's not the way that it's described in literature, but my way of thinking about it is if the atypia that I'm seeing reminds me of ancient change or degenerative atypia of schwannomas, that kind of thing, that I'm relaxed about. I'm perhaps less bashful than many people about admitting to do a Ki-67 on a case, because there's nothing like seeing if one of those nodules is a little bit more concerning looking than many of them. I love seeing it be practically dead negative on Ki-67, whereas other patterns, myxoid yolk sac, etc., of the type that would merit chemotherapy, they will have a much higher Ki-67 proliferative index. And I try to take to heart in my differential, Dr. Albright's words from that 2018 review, where he says that, the pathologist should say, should this patient potentially get high-dose chemotherapy plus autologous stem cell transplant based on what I'm seeing in this RPLND? And if the answer is not that you're absolutely certain they should, then don't make a diagnosis that can trigger that. But I already admitted to sending one that worried me out. Dr. Idris, what do you have to say in this regard?
You're exactly right. Actually, we are very conservative actually, because these stroma that sometimes it looks very juicy. It may be a teratomatous stroma also. And because both of them, you usually don't do GPC3 and stuff, but when you have a concurrent yolk sac tumor and you really think that this is a stroma derived from yolk sac tumors, if it's low grade, we tend to say that it's probably associated with yolk sac tumor and no further treatment is required other than the excision if it is enclosed. Beyond that, we don't trigger that chemotherapy for the patient if it's only that stromal component. So we try to put a low grade spindle cell proliferation, most likely associated with a yolk sac tumor. And our physicians are well acknowledged with that kind of terminology, so they probably would not do anything further.
Thank you for that, Dr. Idris. I'd like to circle back to, go ahead.
So like I want to add that sometimes this is overuse of that caused some troubles also. So we had a recent case actually when there was a unknown malignancy ended up in retroperitoneum. Well, I12P was sent and it came positive, but couldn't find any tumor anywhere in the whole body. They ended up having a sort of small tumor in pancreatic. So we sent both for the genomic studies and both had a good match there. So sometimes it happens that the other tumors, other than germ cell tumors, can have I12P. So you have to be a little bit conservative on that call. So if it's SAL4 positive, I12P positive, it's fine, but you have to caution the physician that they have to find the primary.
Thank you, Dr. Idris. Circling back to Dr. Luenga on the topic of, let's say, molecular testing, and we talked about isochromosome 12P. Dr. Luenga, we have variable adoption of liquid biopsies for microRNA testing. Could you summarize some use case scenarios and how you see practice unfolding with adoption of microRNA testing?
Yes, of course. We of course have been active in the primary identification and testing the stability related to whatever starting material you're using, serum, plasma, but also cerebrospinal fluid in the case of intracranial germs and tumors. I think the bottom line that it's in the setup we have tested, it's amazingly stable. The bottom line is of course the question: what is the minimum tumor load you need for a positive signal? For sure, in our control population, we also have seen, and not we only, but others as well, that there are sometimes a very, very low level of these microRNAs. In a study we did at the Erasmus Medical Center, we found that normal test is what you in fact expect, but because there are germ cells available, there is a low level of these microRNAs, but normally they are not detectable in serum or plasma. So meaning that when there is an intact testes, and we've seen it in different cases where the testis integrity is disturbed, you can have a false positive finding. But specifically now, and that's also what we are doing in the different other studies now, it's about the pattern. I think a little bit detection of the microRNA by definition is not disturbing, but you have to see it in time when it's coming up. And of course, it would be very helpful if you have the measurement at the moment of diagnosis, because then you see, for example, a decline. It's clear that for the stage 1 with an occult metastasis and development of metastasis, it's clear from the studies we and others did that it's not a direct measurement, so you have to follow it in time. But if you compare it to AFP, it seems to be, but we have to wait for the prospective trials, of course, better and informative in the context of a viable tumor. And I want to repeat it for teratomas in our hands for sure, and also in the other ones, it's not informative. It has been reported in several cases that the 375 could be informative. We could not confirm that in our hands. It's not differentiated between normal and tumor. So I think I expect that it will be very positively embraced based on the data of the prospective trials, but we always have to wait before it's implemented. But I think from the technical point of view related to what is the method of detection, etc., that is quite minor because it's so specific and sensitive for the detection. But it's the lowest level, the threshold determination for an individual patient that will be the determining factor to the future.
Thank you, Dr. Loenka. I think we have just time for one last question, and I will request Dr. Nicole to address that, please. In your experience, how from a surgical perspective, how challenging or different is perhaps your experience or strategy towards patients who have a metastatic germ cell tumor with teratoma versus patients who have possibly a retroperitoneal teratoma with secondary somatic malignancy? In your experience, are those cases or your approach different when you handle them surgically? And second question was, in patients who have a secondary somatic transformation, for example, a metastatic rhabdomyosarcoma, in your experience, have you found tumor type specific chemotherapy to be helpful in those instances? For example, patients who have a RMS specific therapy versus perhaps a secondary somatic neuroblastoma specific therapy, could patients be more amenable to those?
So I guess to with the first question, the ones that have dedifferentiation will often have solid components. They are more difficult. They can even sort of rupture because they're often these large friable sort of masses, and so they're sort of more difficult, and you can make more mistakes, I think, is the bottom line. So sometimes things don't turn out as nicely as you'd like. Most teratomas are not always the difficult surgery. They're often large, but they do have, because they're cystic, they have well-defined clinical planes. And so size is a challenge, but they're not as challenging as some of the smaller but densely fibrotic ones, because they're the ones that you end up having to do a vascular replacement, take out an organ, and that type of thing. The other question I think you were asking is, do we drive therapy on the phenotype of the dedifferentiation? I guess, yes, we do. Mostly it's sort of gut and respiratory things where you go along those sort of pathways. They get a modest response, but generally they do poorly, is the thing. So once you've got those, you're in a fairly desperation situation, and their prognosis, it's probably less than 25%. It's not good.
Thank you, Dr. Nicole. Over to you, Samit.
So I think we're at time, and we'll conclude this session. If the speakers could just stay back for a couple of minutes. I thank everybody for joining. We've had some wonderful talks. Obviously, we'll upload this video to our website. So, if you want to come back to it later and just use it as a review while you're looking at cases and to kind of get a grasp of the literature, it'll be available to you. And thank you, everybody, for joining today.
Thank you.
Dr. Fine, are you on?
I'm on. Thank you to everyone. It is recorded. For those of you who use the space once called Twitter, now X, or your colleagues do, each of the speakers is featured in a post recognizing both the event and your contributions. So you can find those things there. And even if you're not in that space, if you Google yourself and put in Twitter or X, you can find the post. I've tried to capture everyone, and highlight some of the work. I think that was great. Thank you so much.
That's a real first for me. I don't think I've ever been X'd or tweeted or whatever it is.
Samson, do we want to do our customary photograph?
I would love to. Is Dr. Smith still with us?
Yeah, I think he mentioned that there was some thunderstorm in his area, so I think they probably got disconnected. I think he mentioned that in his chat. So
got it. I'm happy to do a photo of who we have here. If everyone wants to look at their screen, I will and just hold a smile for a moment. That would be great. Okay, I think I captured us. Let me make sure. Yep, there we go. Thanks so much, everyone.
Thank you, everyone.
Thank you, everybody.
I appreciate the opportunity. I enjoyed it. I learned a lot.
Excellent.
Bye-bye.
Bye, everybody.
Thank you. Bye.